Get some response. So, what is wound? What do you understand by wound, or what do you mean by basically in palliative care? We can see most of the patients who are terminally ill or bedridden, they are prone to get bed sore, right? So what do you mean by bed sore? Anyone? You can use the chat box or you can unmute yourself. What is bed sore? Okay. Pressure ulcer. Bed sore is also called pressure ulcer, decubitus ulcer. So how you will define pressure sore or bed sore? So if you will interact, that will be a good interactive session. At least you can respond through chat box or you can unmute yourself. So that only one medium is not talking and you are also talking, and we can get an interactive class. Any idea about pressure ulcer? Tear in the skin pressure area, Manish. Okay, thank you for your response. Yeah, of course, tear in the skin pressure area. So we can continue. Okay. So what is pressure ulcer? It is pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence as a result of prolonged unrelieved pressure. Right. So when a patient is bedridden, mainly the skin get localized skin get injured because of the undue pressure of especially in the bony prominence. So whenever you can see a bedridden patient, we can assess the bony prominence area for any tear or laceration, so that that is mainly developed because of the prolonged unrelieved pressure, because the patient will be in a one particular state, and because of that the patient cannot himself cannot change the position. So because of in a one particular point for more than 2 to 3 hours or 4 hours, the bony prominence area will get into get unrelieved pressure. Because of that unrelieved pressure, the skin will get injured or teared, and that will lead to pressure ulcer. Okay. So you can see the image. There are different types of pressure ulcer. In forward, we can see what are the stages of pressure ulcer. Right. So most prone area is sacral region, right? So sacral region, more patients get more bed sore, and also in the heel area, which is the most neglected area. So we have to assess for the area where that also we will look after in the next slide. What are the main bony prominence area which we have to assess continuously when a patient is bedridden? Am I audible to all? Is it clear?
Yes, ma'am.
Yes, ma'am. Thank you. Okay, so the what pathophysiology is associated with this is pressure for a long time. As I said, because of the prolonged being in a one particular area, the pressure in that area will be more, especially in the bony prominence area. So long time pressure, that will lead to collapse of the blood vessels. The blood vessels will collapse. That is, the circulation will be impaired, and because of that, the nutrition, oxygen, and the tissue perfusion will not be there. So the skin will not be getting proper nutrition. Because of that, or oxygen deficiency is there, or tissue perforation will be perfusion will be impaired. So because of that, in that area, because of altered circulation and because of deficit oxygen, there will be tissue ischemia or hypoxia, and even this because of absence of oxygen in the cell, there can be cell death, and that will lead to increased stress and breakdown of the skin. So this is the pathophysiology which is leading to the pressure sore. Okay, so what are the risk factors? Can anyone enlist what are the risk factors associated with pressure ulcer?
Long-term bedridden.
Yes, good. More? Bedridden, okay.
Do not change position.
Yes, not changing the position, being in a particular state for a long time. Then unconscious patient, prolonged pressure, okay. Is friction associated with pressure sore? Surabhi is saying yes. How?
Yes, yes.
How? Like when the patient is bedridden, he want to get up. You will be pulling him up towards the bed sheet, right? That bed sheet and the skin surface will rub, and that kind of friction will be developed. And because of that, also because of already the nutrition is impaired for the patient, that can also lead to skin injury, right? So we look into one by one points. Sujata is saying diabetic patients. Diabetic patients, if they are bedridden and prolonged bedridden, because of that unrelieved pressure, they can cause pressure injury. Okay, so first is friction. Like friction, shear, these are all associated with by the bedridden patient. We in the hospital, we are trained to how to shift a patient from a bedridden state to another, from one bed to another, or from a stretchers to the bed, right? So we know how to carry the patient using bed sheets and pulling and picking up the patient from both side and then transferring to the bed. But in the home setting, what will happen? They will be rubbing that patient along with the bed sheet, right? So that friction can lead to skin injury, and also shear pressure that also accompanied along with that, that because of that improper positioning of the patient, that can lead to injury, right? Then impaired sensory perception. Sensory perception, if it is impaired, also can lead to pressure ulcer. Prolonged physical mobility, as one of them has said, because of physical mobility is impaired or bedridden patient, they are more prone to get bed sore. Okay, then altered level of consciousness is the patient is not in conscious, that will lead to bedridden. So that can also cause bed sore. Okay, so fecal and urinary incontinence. How this is causing bed sore? Fecal and urinary incontinence. Yeah, you can speak in Hindi also. I know Hindi. You can speak in Hindi. No problem. Fecal and urinary incontinence, how it can lead to bed sore? What will happen if fecal and urinary incontinence happens? The patient will be more in water, moisture, right? So that moisture, when moisture comes in contact with the skin's integrity is impaired. So that will lead to pressure sore, right? So that is fecal and urinary incontinence. Mainly it happens in a bedridden patient who is prolonged in the bed and nobody is there to take care. Like if only earning member is one the patient who is get into that terminally ill stage, that patient was the only earning member, and other person like if the father of that family is bedridden and the mother is going for the duty, right? So what will happen? Morning she will change everything and go, and evening she will be back. At that time, what will happen? The diaper will be full, and the patient will be passing fecal and urine, right? So that will lead to moisture development. All everything will be wet along with the bed sheet. The patient's skin will be wet. So that moisture will lead to development of the impaired circulation can happen, and then the patient can develop bed sore, right? Then malnutrition, as one of the among you all have said, that malnutrition, that is the patient will not be getting proper nutrition. So because of that also pressure sore can be developed. And dehydration means when the fluid level in the body becomes less, that can also lead to drying of the skin, and that drying of the skin will come in contact with the surface, like friction develops, the tear can happen, or the wound care pressure sore can develop, right? Then excessive body heat. Do you agree excessive body heat can cause pressure sore? I'm asking just do you agree? Yes or no? Anything, any answer you can say.
Yes, ma'am.
Okay, so excessive body can develop pressure heat, right? So what will happen when the patient's body get excessive heat when it comes in contact with the bed sheet that surface? What because of that increased pressure, excessive heat in that area can affect the skin and the circulation can be impaired, and also there can be leading to the necrosis and pressure ulcer can develop. And also advanced stage, because of advanced stage there can be many reasons, because of nutrition deficiency, because of dehydration or dry skin, that can lead to pressure sore, right? Then what are the common sites of pressure ulcer? Right, so the image is already given. What are the common locations of pressure ulcer if the patient is in a supine position, if the patient is in a sideline position, if the patient is in the Fowler's position or in the wheelchair, right? So whenever the patient is in the wheelchair, so what education we provide to the wheelchair patient in order to prevent bed sore? Can anyone tell what assistive devices we can give to the patient?
We can give pillow.
Yeah, cushion or pillow we can provide to the patient in the hip region they can put, or in the sacral region they can put, right? So these are the main pressure point areas. We'll see one by one in the upcoming slides. Okay, so these are the pressure sore images, which are different sites are there. Mainly we have to look into the bony prominence area. The bony prominence area are more prone to get pressure ulcer, like in the occiput, in the like what we can say, in the shoulder, scapular region, there in the buttocks region, sacrum region, and also especially the in the heel area, which is mainly heel area is the most neglected area, or the little finger area, that are the most neglected area. When already the stage is just like second stage is crossed, we will be looking into that. So in whenever we are as a nurse, we are going, or as a doctor, we are going to a bedridden patient, we have to look into, or we have to educate the patient regarding these all areas in order to prevent bed sore, right? Okay, so common sites. So we can look into first site, that is supine. So in the supine, mainly the head, that is occiput area, then shoulder region, elbow region, buttocks region, heel region, and also toe. These are the more areas when the patient is in a supine state for a more than 2 to 3 or 4 hours. So we have to check these areas for impaired circulation. So what if you see a redness in these areas? So what you will do if a redness is there in that areas? Okay, Lakshmi is saying stand up every 10 minutes for 10 seconds. So if the patient cannot stand, then so change the position. Sujata is saying change the position. Yes, of course, but for how many hours? After how many hours? If a patient is in supine for more than 2 hours, then or 3 hours, then what do you have to suggest? Okay, Ravina is saying 2 hours. Yes, so we have to tell the patient that every 2 hours they have to change the position. Thank you, Lakshmi. Change the position every 2 hours, right? So every 2 hours you have to change the position, and you have to look for the bony prominence area for any kind of redness. And if you see a redness, then what we have to do? We have to do something. We have to rub it. If it's a mild redness, rubbing is okay. But if it is a very like very hard reddish is there, and the skin are like about to remove from that area, when you will put the hands or you will rub, the skin will be torn away. So that's why whenever you see a complete red area, you should not touch that area. Deciding area you can give a massage, but in that area you have to always be conscious that you should not rub it, because if you will rub it, it will go into the second stage of ulcer, right? So rubbing is not allowed, but you have to check for the areas where slight redness, okay. But if it is a deep red in color, you should not rub it, because that skin will be coming out, right? And it will be mainly severely painful, right? Okay, so the common sides in sideline position is either it is right or left, ear area, shoulder, elbow, that is mainly outer side of the elbow, hip, knee, inner side of the knee, outer side of the knee, ankle, and also heel. So in order to prevent inner side of the or outer side of the what we can say areas or the pressure prone areas, what we can suggest to the patient or the caregiver? What we can suggest? Like we suggested for a wheelchair patient, same we can suggest for the patient who is in a sideline position. Mainly the knee areas are more prone to get bed sore, so we can provide a cushion or a pillow. Okay, so that that area will be not touching from one or the other. The knee will not be touching each other, and it will be separated, and that area will be relieved from unrelieved pressure. Okay. Next, Fowler's position. So Fowler's position, as we know, these are the position which the patient is given when the patient is in a respiratory distress. We mostly prefer for Fowler's position, semi-Fowler's position, right? So when the patient is more like COPD patients, they are more in the last, like in the most exacerbation state, the patient will be in a Fowler's position. They cannot even sit or stand properly. So they will be attaining the Fowler's position. So at that time, if the position is not changed, then that can lead to pressure sore, mainly in the head region, that is in the occiput region, shoulder region, sacrum region, buttocks region, and also heel area. Okay, buttocks mainly ischial tuberosity, where the hip bone is there, right? Then prone. Prone, mainly we attain this position when we are doing any procedure, right? If a long-term procedure is there, we have to educate the patient regarding the prone position, and also where the bony prominence are, where in time to time they have to, like if undue pressure is there, how to relieve the pressure. These all are education we provide to the patient. So when the patient is in the prone position, we have to have an idea that what all areas are there which are more prone to get pressure sore. That is in the head, in the elbow, in the chin area, chest, reproductive organ area, and also knee and toe area. Okay. Then what are the stages of wound? Can anyone tell what are the stages of wound? You all know what are the stages of wound. It's just a general discussion topic. Okay, stage 1, stage 3, stage 4. So 1 and 2, after 1 and 2, 3 and 4 will come. Na? So stage 1, stage 2, stage 3 and stage 4, and also stage 5 is there, and also stage 6 is also there. That is deep tissue injury. Okay, so I'll let you know what all are they. First is stage 1. As I said, there is a slight redness in the skin. So whenever you see the stage 1, you have to be extra conscious, right? So this area is called as a red differentially colored spot that cannot be blanchable with the pressure. When we are putting a little pressure on that area, that is non-blanchable. That is non-blanchable erythema. That is when we press it, basically that redness has to be disappeared. But in this pressure sore area, when you will press it, what will happen? There will be non-blanchable erythema. That redness will not go when you are putting a pressure, right? And but we should not rub that area, because if you will rub, that skin will be torn off, right? So first stage is non-blanchable erythema. Second stage is partial thickness skin loss. That is shallow open ulcer into the dermis, serum filled blisters. Okay, so what will happen? Mainly there will be a shallow ulcer in the second stage, that is partial thickness. Partial thickness skin loss means only the first 2 layers of the skin that is becoming like injured, right? So the shallow open ulcer into the deep dermis, and also serum filled blister, that is there will be exudate formation, that is the fluid will be filled and that will be looking like a blister form, right? So second stage is this. You can see the picture. Okay, next is stage 3. So full thickness ulcer. So full thickness ulcer means epidermis, dermis, epidermis, and also the subcutaneous fat layer is also what we can say is impaired, right? So what will this image is showing? That is full thickness ulcer. Almost all layer of the skin is destroyed, right? And also in this, the important thing we have to consider is that is tunneling. Tunneling means that is in the, there will be a pocket-like formation. The skin will be folding inside. So you can see in the side. Okay. Okay, this I am showing it in the mouse. You can see the mouse pointer where it is.
Ma'am, can you repeat the question?
Okay, sorry, I didn't repeat it. I was just telling. See, you can see the mouse pointer in the image, right? So when you are seeing the mouse pointer is not coming. Okay, now you can see the pointer. Okay, so this area in the boundaries of the ulcer, there is a tunneling. Tunneling, you know, गुफा जैसा ना, tunnel जैसा बन जाएगा, right? So there will be a tunneling in this area, right or left, or in any area in the wound, there will be a tunneling. So in the third stage, whenever you see a third stage pressure ulcer, you have to think first is it is a full thickness ulcer in which all the layer of the skin is gone. You have to check for the tunneling, which is very important. Tunneling, we have to see how much, like you can use a what we can say, a stick, a tongue stick like that, or an artery which is covered with a gauze. A simple artery can also cause a laceration. So you can like curved arteries, you can use it, and you can see how depth the tunneling is, right? So the narrow opening or a passage that can extend into any direction, that can go into any direction through soft tissue, that is called as tunneling, right? So this you have to remember whenever you see a third stage ulcer. You should look for the tunneling, right? See, a stick is there. You have to check whether how much depth the tunneling is. In this image, only one tunneling is seen. But we in lively, when we see a patient, there can be many in different areas, right, left, okay, side, besides, everything. That circle, anywhere there can be 1 or 2 or 3 tunnelings, right? And next is stage 4. Stage 4 is mainly exposed muscle, bone, tendon. Whenever we see an exposed muscle and bone tendon, that is called as stage 4. Right? That means epidermis, dermis, subcutaneous layer, and muscle and deep tendon, everything is visible. So that stage is called as stage 4. Can anyone tell what is the stage 5? Have you heard about stage 5? Yes or no?
No, ma'am, we have learnt about still stage 4 only.
Okay, Jagrati has learned only till stage 4. Anybody else? We are 45 in this room. So anyone can respond. So I think along with Jagrati, everyone is familiar with only stage 4, right? So stage 5, I assume that because you are not responding. So stage 4, one more image is there. You would have seen this kind of pressure soles. Have you seen the images which is shown the stage 4? Have you seen this kind of pressure soles?
No, ma'am.
Okay, one answer no. Deepa is saying no. Manish is saying no. Then at least no can pop up as many as you can. Yeah, Lakshmi, no. Okay, thank you so much. So stage 4 is exposed muscle and bone tendon. So stage 4, you can see when after getting into palliative care, you can, whenever you go for a home visit or when the patient comes into your clinic, you can see this kind of pressure sore, right? Next is unstageable. That comes under fifth stage, right? Unstageable means the wound is covered with a scar or dead tissues, right? So once you remove that dead tissue, only you will be able to know is it a 4th stage or it is a 3rd stage, right? So when you will, most probably when you remove an scar, that is mainly a 4th stage only. Okay. The pressure sore that is unstageable and it has a slough or eschar. Slough means dead tissue or eschar, right? So when you remove, debridement is done. When you remove that dead tissues from that pressure sore, then only you will be able to identify whether it is a stage 3 or stage 4 ulcer, right? And also there is a stage 6 that is called deep tissue injury. Deep tissue injury means we can say that whenever the patient in the bedridden, you can see a purplish color. Have you seen purplish color bed sore?
No, ma'am.
Purple, like it will be like the blood is inside, like blood is dead inside. That kind of, when you get a bruise like that, na, same that kind of thing. Have you seen in a bed sore bedridden patient? Okay, I assume no. So, but the deep tissue injury is what? Deep pressure injuries, as it is in the image, it is like a bluish discoloration. So that is mainly non-blanchable, deep red, purple or maroon discoloration because of prolonged pressure or shear force, right? And also tissue damage from inside out, that is stage 3 or stage 4. So whenever you see such kind of deep tissue injury, either it can be from inside to out, it can be 3 or 4. So what is this? Mainly this is showing that the patient has developed the pressure sore, and because nobody has touched that patient, that skin is not removed from that place, right? So it is retained in that place. And when we will check whether how much is the depth, we will see from inside to out, it will be stage 3 or stage 4 pressure ulcer, right? So deep tissue injury is also a new one which is added in the in this like wound management slide. So this is very important. Stage 5 and stage 4 is stage 6 is very important. That is stage 5 is unstageable and stage 6 is deep tissue injury. Is it clear or shall I repeat it once again? Again, this is also a yes or no answer. Shall I repeat it or not? Okay, Lakshmi is giving me a green signal. All clear, Mahesh. It's look like purpura. It's yeah, we can consider that it's look like a purpura, but it's not. It's mainly a non-blanchable deep red tissue. All the layers has been impaired, and because of that, improper circulation means why that above skin is not teared, right? So when the above skin becomes out or it is teared, that time only we can go into the stages. But what happens in the deep tissue injury? Only that circulation, because of that circulation is impaired, there can be impaired circulation, that redness, that blood has been accumulated there and retained there, right? So it can be said like that, right? So maroon discoloration will be there, and once the force or any kind of friction is applied, it can go into 3rd or 4th stage, right? Okay, so what are the assessments we have to do? As a nurse and a doctor, we must assess the patient's skin at each visit whenever the patient is bedbound or in the wheelchair patient. So we have to assess for the pressure points. We have to assess for the pain associated with wound, and assess for the location where is the main pressure area, right? And measure the length, width, and depth of the ulcer, and stage of ulcer, presence of any exudate formation is there or not, that is any oozing is present or not. Then assess for tunneling. Which stage we are assessing for the tunneling? It's all clear now. Then give me an answer. Assess for tunneling. Which stage we have to assess for tunneling?
Stage 3, where subcutaneous fat is involved.
Okay. Okay, I got many response from, along with Jagriti, Manish, Deepa. Everybody is saying stage 3. So I think it's clear for you. So yes, we have to assess for the stage 3 for any tunneling is present or there, and then chart the finding. We have to use the wound chart, and then we have to chart that findings, whatever we have got. So whatever things, that is pressure point area, the pain associated with the wound, location, and the width, length, and the depth, stage, exudate, tunneling, and findings. You have to chart it, right? then management. So there are difference, like when we are doing a management, always medicate the patient for pain before wound care. Why we are saying that before the wound care we have to medicate the patient for pain? Because it will be painful, right? So whenever we are doing we know that the patient has severe pain while we are doing a dressing, we can give a medication like analgesics, or we can use lignocaine, right? So that the pain can be relieved. Then we can also stage 1, we can teach the caregiver how to change the position. That is, changing the position is very important whenever the patient has stage 1 ulcer. And also excellent incontinence control. Incontinence control, we have to teach them that because of the prolonged moisture in the skin, that can also lead to bed sore, that we have to teach the caregiver, right? And stage 3, that is cleaning and dressing with the normal saline. Whenever we see a stage 2 bed sore, we have to clean that bed sore with the normal saline, and also we can do a dressing. Plain dressing we can do, because that plain dressing, if we provide a dressing, the patient will be aware that we don't have to put more pressure in that area. That can be a main, we can suggest them, right? Then stage 3 and 4 and unstageable, as we said, that if there is any a scar or slug is there, surgical debridement can be done. Then normal saline, we will tell them how to make the homemade saline. In upcoming slide, we'll see, in order to clean the wound, normal saline, we will tell the patient how to make it in a home setting. And if there is an odor or infection, we can use metronidazole powder. So we can take the metronidazole tablet, we can crush them into fine powder, and we can apply in that area. That is a single layer, a slight layer only. And also gel lubricant, we can, along with the gel lubricant, we can mix that metronidazole powder, and then we can spread it. Either we can use it liquid paraffin, or we can use a white petroleum jelly and spread it on the wound. And also debridase ointment, we can use it. And also Megahil, in order to promote granulation of the tissues, we can use Megahil ointment. Okay, so if foul smell is there, right? So if foul smell is there, we can tell the patient to use charcoal. Mainly, it can be kept under the bed. So what happens is, charcoal has the power to absorb the bad odor or malodor, right? And also avoid hydrochloride solution like povidone iodine and hydrogen peroxide. In our palliative setting, we are not using povidone iodine for any kind of dressings, or even hydrogen peroxide for dressing, because it can irritate the skin and cause more worsening of the pressure sore, right? So maximum avoidance of the povidone iodine and also hydrogen peroxide, and also using of the charcoal in order to absorb the malodor. And surgery consultation is, finally, if that wound is not healing and if surgical intervention can be promoted, we can go take the patient for the surgery consultation. And also negative pressure wound therapy we can give. That is, negative pressure wound therapy is mainly, we can use the wound sucking machine, right? If that wound therapy machine is put it in that pressure area, that will be sucking that all the exudate from that wound and making that wound clean, right? So that is called as negative pressure wound therapy, as it is shown in the image, right? So how you will make a homemade, like how you will educate the caregivers and the patient and the family how to make a homemade saline and dressing supplies. Okay, so homemade saline is mainly normal saline. How you will educate them to make it is using 500 ml of water, add 1 teaspoon of salt, boil, cool, and then keep covered until needed. Okay, so half liter of water, that is sufficient, along with 1 teaspoon of salt. Okay, and it has to be boiled well and then cooled and covered with a lid. Then wound are not sterile, so saline has to be clean only, not sterile. Then gauze. Gauze is how to sterilize the gauze is, take old cotton saris or dhotis, cut them into square, steam them for half to 1 hour, may impregnate them with Vaseline or liquid paraffin. Okay, so we will suggest them, like the steamer will be available, or if steamer is not there, they can use a container. They can fill them with a little bit of water, keep one more bowl and place it ulta, that is down, right? And then above that, they can use a container and keep that all the gauze which is cut, that is a dhoti or a sari piece that is cut into a square piece, and then they can put it everything inside and cover it with the lid. So because of that steam, the bacterial presence of bacteria can be prevented, right? So half to 1 hour, we have to suggest them to steam it, and then after that moisture is gone, they can cover it in a airtight container. And whenever they are using, because the gauze will stick to the wound, they can use a Vaseline or a liquid paraffin in order to provide moisture or lubrication, right? Then prevention of bed sore. As you have all said, change the position every 2 to 3 hours for a bed-bound patient, every 15 to 20 minutes for a wheelchair-bound patient. And how to manage incontinence, that we have to say, suggest them, and also artificial special surfaces, that is assistive devices, that is air mattresses, water mattresses, pillows and cushion we can provide. This is very important. Whenever the patient is bedridden, first we have to, in order to prevent, that is preventive strategies that comes under this, that is we have to suggest them either to use air mattress or water mattress, right? So mostly they prefer air mattresses, because water, there can be a cold sensation, and that can also develop moisture, right? So these are the images. This is an air cushion, air mattress, and also this is a water mattress. Okay, so we have gone through the prevention strategies, but this is an SSKIN. This is a immediate, what we can say, immediate quick rememberable thing, that is SSKIN. S stands for supporting surface, that is supporting surface, that in order to prevent the pressure, we can use proper supporting devices like air mattress, water mattress, cushions, right? And also skin inspection. Skin inspection is very important. Whenever we are going for a visit, we have to check for the bony surfaces for any kind of redness, right? And also suggest them to keep moving. K is for keep moving, that is change the position every 2 to 3 hours whenever they are in the bed, and all whenever they are in the wheelchair, 15 to 20 minutes. Then incontinence or moisture control, which is very important, how we can suggest them, that is through either bowel or bladder care can be given through catheterization if required, or either through changing the dressing when it is wet, and also diaper change as per needed. When it is not wet, when it is completely filled, at least when we can see that it is already filled up, we can change it, so that the wet diaper surface will not be in contact with the skin, and that can cause pressure ulcer, right? And N for nutrition. So whenever there is a pressure sore patient, or the patient can get pressure sore, we have to suggest them nutrition strategies. That is, we have to tell them to take protein rich diet, or include protein rich diet in the meal, right? Then so SSKN is clear, supporting surface, skin inspection, K for keep moving, that is changing the position, incontinence, and nutrition, right? Okay, so engage patient and family. How we will engage patient and family? We have to involve patient along with the family in order to prevent pressure ulcer, and also develop a contract of care. That is, from the time of first visit to the upcoming 2 weeks, we will tell them how to care the wound, and then we will make a contract that within the 2 weeks duration, proper dressing and proper nutrition can make the pressure sore better. We can establish a contract. Then what can we do together to prevent ulcer? What we together do means, in the palliative setting, we not only engage with the patient, we include the family also. So if any kind of support, like they are not able to afford air cushions or air mattresses or water mattresses, we can provide them with the mattresses, and we usually provide them with the mattresses, so that we work together in order to prevent the bed sore. And also we can provide patient information leaflet. Patient information leaflet, this is a Malayalam leaflet. So whenever we can take this kind of leaflet in the home visit, and we can suggest them whenever the patient is there in the bed. Every 2 hours, we can change the position from one position to another. That is, if the 2 hours the patient is in supine, we can change in the right sideline, then we can change in the left sideline. So this kind of leaflet will make it easy for the patient to remember that what all we have suggested them to do, right? Okay, so hope pressure sore is clear. Now we will look into fungating wound or cancer wound. Have you anyone has seen fungating wound or cancer wound? Again, it's a yes or no question. Have you seen? Yes or no? Yes. Okay. Kavita is saying yes. Deepa is saying no. Uh, can you unmute yourself, Kavita, and say what kind of cancer wound you have seen and what is the difference between a normal wound and a cancer wound? You can type also, no problem. Yes, Manish is also saying yes. Fungating wound or cancer wound, if you have seen it, what is the difference between a cancer wound and a normal wound? Okay, I can give you points. You can again say it in yes or no. Is it preventable? Is it preventable? Yes or no? Is cancer wound preventable? No. Is it curable?
Yes.
No. It's not curable. That is the difference that makes from a normal wound. Okay, so normal pressure wound, that is preventable and curable. We can cure to an extent, right? By the preventive strategies and the management, we can like cure and prevent wet sore. But in a fungating or a cancer wound, it is not preventable or curable. Why? Because of its appearance. You can see in the image, next image. As you can see, you may have seen this kind of cancer wounds only, right? It is a cauliflower shape, right? Or fungus nodular fungus type or cauliflower shaped wound. Have you seen this kind of wound? See a breast patient, you would have seen, or mandibular area, see a mandible or tongue, you would have seen. Yeah, Kavita has seen see a breast case. Okay. Yeah, same. Okay. So what is the difference between a normal wound and a fungating or an cancer wound is normal wound can be preventable and curable, but the cancer and fungating wound is not preventable or curable. So it is a primary, as a definition says, it is a primary or secondary malignant growth in the skin which has ulcerated or difficult to heal. Primary and secondary malignant means either it can be a first or second malignant growth in the stage of growth in the skin that has an ulcerated, that is already ulcerated, very well ulcerated and difficult to heal. Okay, so this kind of ulcer is foul smelling or not? Malodor will be there or not? Again, yes or no question. Foul smelling will be there or not? As you can see in the image only, you can imagine it is foul smell will be there or not. Manish is saying yes. Yes, okay. So the term fungating refers to a malignant process involving both ulceration and proliferative growth. That means whenever we see a wound, that is a cancerous wound, in the next week it will be developed, that is proliferative growth will be there, and that will lead to more ulceration and it will look like a cauliflower shape or a nodular fungus shape, right? So it is normally it is a wound, but it is ulcerated and difficult to heal, and there will be an over proliferative growth of the tissues or that ulcer, right? Okay, so what is the pathophysiology? Mainly develop a non-tender skin nodules. Okay, as we say in the cancer wound, whenever there is a cancer, the nodules, when we assess the skin, the non-tender skin nodules will be developed. Okay, then that nodules will be enlarged. Then because of that enlargement, there will be disruption in the capillary and the lymph vessels. The circulation will be impaired in the capillary and the lymph vessels, and that will lead to altered coagulation and disorganized circulation, and that will lead to tissue hypoxia and necrosis. So what is the difference? Difference is what? The only thing is there will be a nodular formation. Whenever there is a pressure sore, there will not be a nodular formation. But in a cancer wound or a fungating wound, there will be a non-tender skin nodule which will be enlarging in the size. Because of that enlargement in the size, the capillaries and the lymph vessels will be, that circulation will be disrupted. Because of that, the coagulation will be impaired, disorganized circulation, and that will lead to tissue hypoxia, that is oxygen deficiency in the tissue, and that will lead to even necrosis, cell death, right? So this Marjolin's ulcer is also, you would have seen, mainly this is a type of malignancy of the skin. Malignant changes in the chronic wound. Chronic wound means non-healing wound, like it can be because of burn scar, pressure ulcer, venous leg ulcer. Okay, so venous leg ulcer or pressure ulcer and burn scar, like in I don't know in the normal setting you would have seen, but here in palliative care we are seeing this kind of chronic wound. That kind of type of malignant skin wound is there, that is called as Marjolin's ulcer. That is a malignant changes in the chronic wound, that is, it is also non-healing. This will not heal for a lifetime. Whatever dressing or a medium we can use, this is not preventable and curable. The burn scar, it will not heal. Pressure ulcer, it will not heal. Venous ulcer, leg ulcer, that will not heal. Okay, so these kind of malignant changes in the chronic wound, that is called as Marjolin's ulcer, right? So what is the pathophysiology? See, appearance of mass in the wound. There will be a mass in the wound. Because of that mass in the wound, there will be onset of wound pain not previously present. That means when the patient got admitted, at that time patient was not having any pain, but frequently the weeks develop, there is a mass in the wound, and that because of that mass in the wound, there is a pain which was previously not present. Okay, at present the patient will be having pain, but previously he was not having pain. So this is the first sign which indicate that the patient is going into Marjolin's ulcer. So change in the character, volume, appearance of the drainage. So whatever drainage or exudate that is coming from, it has got changes. And also whenever we do a biopsy wound, the malignancy will be there, right? Okay, so next is problem. So whenever we are looking into a palliative setting, we are looking into a holistic approach, right? So physical, psychosocial, psychological, spiritual, and social. 4 aspects we have to look into. So what do you think? Physical will be there, right? In the patient who is having cancer wound or Marjolin ulcer, patient will be having physically pain, malodor will be there, right? Malodor will be there. Why? Because as I said, there will be that uncontrolled proliferative growth of the cell that will lead to malodor, bleeding also. Okay, because there will be that vascularity will be like overgrowth will be leading into bursting of that vessels, and that can lead to like it is very sensitive. When you will touch only, it will bleed. Then exudate, even touching also, because of that pressure, it will get bleeding normally, even if we don't touch also. Then exudates will be there, itching will be there, patient will be complaining of itching, infestation with maggots. If any flies will sit in that area, if it is uncovered, the flies will sit and it will lay eggs, and that can cause infestation with maggots. Then communication difficulty, the patient will not be able to communicate socially. Because of the pain also, the patient is not able to communicate. Okay, so communication difficulties will be there, right? Then psychological, that is altered body image. The patient will be having altered body image. He will be completely isolated. So sexuality, the sexuality will be lost. Denial will be there. That fear will be there. Depression and anxiety will be there. Shame and guilt will also be there, right? So why these are all there? Like along with the physical problem, mental problems will also accompany. The patient will be not going, because of that ulcer, patient will think that foul smell will interfere with the society. They will be looking me in a different eye, right? They will not consider me as a part of society. So these all, and even the female patient, if CA breast patient has this kind of ulcer, the patient will not be like mentally will not be satisfied. Even what my husband will think, I am foul smelling, these kind of thoughts will be there in the patient, right? And also denial will be there, like they will not be accepting the reality. Fear will be associated along with that. Depression, anxiety, it will be accompanied along with. Shame and guilt will also there, why I have developed this kind of ulcer, right? Then social, complete social isolation will be there. Social family isolation along with social isolation both will be there. Social stigma, nobody will be going into that patient's house, right? The fear of contagion, that it will spread. Mostly in like in south it is not that much prevalent. In north areas they are telling if somebody gets cancer, if they will say don't go to that house, you will also get that, right? So this kind of stigma, superstition is there. Then effect on the family will be completely collapsed, right? Because by listening, see cancer word itself, they are collapsed, right? Then effect on sexual relationship. Of course, sexual relationship with the reproductive age group family will be hampered. Marital disharmony. Even you would have seen if the patient get cancer, the either the wife will leave him or the husband will leave, right? Go away. They will not be living together. They will be separated. So this kind of marital disharmony will be there. Then spiritual interference with the religious rites. There can be fighting with the religious will be involving. They will be saying that you come to our religion, we will cure you. Such kind of things you would have heard it, right? Then punishment from the god. The patient will think that this is a punishment from my god. I have done such and such, that's why god has punished me, right? And fear of impending death. I will die now, I have got cancer, within 2-3 months I'll die, right? This kind of mental chaos will be there in the patient. Okay, so what do you think? In your areas you have met with this patient, this kind of patient who has got cancer, and the patient is dealing with physical, social, psychological, spiritual, every aspect is impaired. Again, a yes or no question. Yes or no? In your area, it is there or not? Nobody is there. Only we have got such kind of patient. Jagrati left. Pooja. Okay, so maybe you have not encountered such kind of patient, right? Yes, Pankaj, you were about to say something. Yes, yes. So there are patients, right?
Yes, ma'am.
Thank you for your response. Okay, so in this kind of patient also, we do a thorough assessment, that is wound location, where the wound is located, mobility impairment. If that presence of wound is impairing his mobility, easily covered with the public view or not, right? So, and the wound appearance, how the wound is appearing. So if it is a fungating ulcer, that it will be a cauliflower shape. Surrounding skin, how it is, right? And also potential for complication, like potential for obstruction or hemorrhage from the major blood vessels, right? So if it is in the neck area or in the facial area, it can hamper the jugular vein, right? So it can extend towards the neck and it can impair the jugular vein. So it can also burst, and that major potential complication, life-threatening complication can also develop. Then what are the principles? So principle associated with palliation of symptoms, that is we have to like symptomatic treatment we have to follow, that is the pain will be there, so reducing the pain, controlling the odor and infection, managing the exudate, and minimizing the bleeding. So these are the palliative symptoms which we have to follow, that is reducing the pain, controlling. We can reduce the pain by adding analgesics. Either it can be first step, second step, or third step analgesics, and also controlling odor and infection, managing the exudate. So controlling odor and also this kind of pain like nociceptive pain or neuropathic pain, we have to deal with the WHO ladder. Then controlling the odor and infection by using charcoal, or also we can use metronidazole powders or irrigations. Then managing the exudate, we can manage the exudate by proper dressing, by using the dressing, sterile dressing materials, and also minimizing the bleeding by giving ethamsulate and all, right? Then also holistic care, that is we have to look into why we are like in the palliative care we are focusing on holistic, that is complete care, uh, physical, psychological, social, and spiritual. Why we are focusing that? Once the patient gets disease, he will be physically impaired. Because of his physical impairment, he will be having mental issues like, now who will be look after my family? how my family will earn, right? How we will get a piece of bread to eat. So these all thinking will be associated. Along with that, spiritual and social will be accompanying, right? So we have to focus on the holistic care, and also what all palliative factors we can manage along with the patient and the family, we can provide help them. Like in this Pallium India, we are providing education support to many of the patient who has got small children, and also even they are in the college and they cannot go to, they have the they have the knowledge, or they have the what we can say, मतलब वो चाहते हैं कि जाना है पढ़ना है, like that, right? So they want to study, they have ambition or aim, so they can go into like we as a Pallium India, we are supporting such kind of patient, right? And also empowering patient and family in wound care. So whatever wounds preventive and management strategies we have learned, we have to empower them that they can do it and they can go forward, right? And also you can make a wound that is non-audible, that is order, malodor can be relieved, pain can be controlled. If symptoms are controlled, the patient will be happy. Okay, so empower them, that is very important. Then criteria for wound dressing. So what are the criteria for wound dressing? Mainly goal of care will be to maintain or improve quality of life through symptom control. As I said, symptom control is very important, and we have to be empathetic with the patient. Whatever care we are providing, that should be empathetic care. That is, we have to be into the patient's shoes so that in order to understand the feelings, right? So we have to be empathetic, provide empathetic care, provide a thorough bath before dressing. We have to provide a thorough bath before the dressing, so that if a fungating wound is there, we will tell them go, we'll remove the dressing and tell them to go and take bath. So while they are bathing, all the dead tissues will be removed from that area, and then we will go for a dressing. Then ensure the patient had a dose of analgesic before dressing. That is very important. While we are doing, the patient will be having pain. As we said, in the fungating ulcer, pain is the key symptoms, which was not present earlier, but now the patient is having pain. So we have to give an analgesic, and also how to use normal saline for cleaning the wound, that has to be educated, and how to select the dressing, right? So that is also very important. Then minimizing pain, that is deep pain, that is aching, stabbing, continuous pain is there. Then we have to adjust the systemic analgesic. If it is just a superficial pain like burning, pricking, that kind of local pain, that kind of pain is there, we can go for a local application, that is sensorcaine and lignocaine, right? Then malodor, as I said, in order to prevent malodor, we can use the charcoal. Okay, and cleaning and dressing the wound daily. Local metronidazole tablet we can use, crushed it into powder. IV metronidazole irrigation we can do. Systemic antibiotics we can give, and also frequent changing of the dressing. No hydrogen peroxide or betadine, right? Because it can irritate that surface. So bleeding, in order to prevent bleeding, we can apply a local pressure dressing, pressure applicable dressing we can provide it. Tight, that means tight dressing. Then prevention, that is, we have to consider that fungating wound will bleed, so we have to prevent that kind of any kind of things. Like if you are removing that dressing, one day evening dressing has done, morning you will change. So morning, at that time you are changing the dressing, you are vaguely pulling that gauze, it can be cause bleed. So what we can do is we can soak it in the normal saline, and then frequently we can remove it. Then apply local pressure. Sucralfate powder we can use it, tranexamic acid we can use it, and ethamsulate, systemic ethamsulate, palliative radiotherapy we can give, and also dark color cloth we can give to the patient so that the patient will not panic. Okay, so what is the role of cancer therapy? That is, cancer therapy, what we are doing, radiation, we are going for the cytotoxic chemotherapy, hormone therapy, and also surgery. Okay, so maggots. Have you seen maggots? Now in the image, right? Have you seen maggots?
Yes, ma'am.
Okay, Pankaj has seen, then Manish has seen. Nobody else has seen maggots? Neha, Sujata, Deepak, you have not seen? Pooja is saying yes, seen. Good. Then few more. I will be happy that you are responding. Yes, in dog bite wound. Okay. Yes, ma'am. So Surabhi is saying yes. Ravina is saying yes. Dr. Deepak is saying yes. Deepa Negi is saying yes. Chetna is saying yes. Thank you. Thank you for your response. So most of the people has seen the maggot. So whenever you see a maggot, first is prevention. That is, you have to you should not allow the flies to sit in that wound, right? So that is the one preventive strategy. That is, we can use mosquito nets, we can use maintain personal and environmental hygiene, which is very important, and also covering, dressing, proper dressing with the clean sterile gauzes or even cotton dhotis or cotton saris. We are using it for the dressing, that should be sterile. Okay, so homemade regime is very important, that what we have to tell to the family and the caregiver. And also apply turpentine. If so, the maggots are already come, right? Your patient is coming and saying something is crawling inside the wound, right? So what we can do is we can apply a turpentine, right? Turpentine we can use, that is because of that smell. We can soak the gauze and we can place the turpentine in the wound. Because of that smell, the maggots will be coming out. You should not follow the maggots. That is very important. Whenever you are doing a maggot, you are seeing a maggot wound, you should not follow the maggots, because there are many small pockets in the wound, right? That is small house is there which is built by the maggots, right? So that small house, they will be running in along that whenever there will be a disturbance in the wound. So what will happen, we should not, along with the artery, we should not follow, because if you will follow the maggots will be going into deep, and that can cause injury and bleed. The wound can bleed, right? So whenever you are using a turpentine, you have to soak it, wait it for 15 to 20 minutes. Automatically the maggots who are residing inside the pockets will be coming out because of that strong smell, right? And also physical removal, we have to remove it, put it in a kidney tray with the warm water or hot water, so that the maggots will be put it inside, it will be dead, right? And the wound should be covered with the dressing all the time and changed daily. That is very important. Whenever like we have got a wound, we have to suggest these preventive strategies, and if the maggots are developed, we have to tell them, cover the dressing with the turpentine. We will not every time we will put that turpentine soaked gauze inside that. We will not, only temporary we will do it. So once the maggots are one by day by day, you will go. So the first day the patient get admitted, what will be got a 50 or 100 200 maggots, right? So what will happen, we'll use the turpentine and then everything, we will do a thorough dressing and all. Next day when you will open that maggots and we will place the turpentine, the count will be lessened. So that makes the dressing effective, right? So once you will get a 200, next day you will get 150, then next day you will get 50, like that. So initially within a couple of days, the maggots can be removed from that wound, right? So important thing to remember is prevention. First is prevention, so that the maggots will not be developed. And if the maggots are developed, we have to apply a turpentine dressing, and then we should not follow the maggots. Never follow the maggots with the artery, because there are so many small pockets, they will be going inside, and that when we will follow it, the arteries can puncture the small that area wound, pressure sore area or the fungating wound, and can lead to bleeding, right? Thank you. So hope I was clear. If any doubts, you can ask me. Anything I have to repeat, or you want to share from your side, what kind of patients you are seeing and what kind of wound you are seeing and what kind of management you are doing there. So I will be happy to hear that. And I have never been into Uttarakhand, right? You all are attending from Uttarakhand. Again, a yes or no question.
Yes,
You can
ma'am.
say yes, yeah. Okay, so I have never been in that area, or rest areas I have been there. So you can share your experience, what kind of wound you are going through. You can see in your day-to-day life. The patients will be coming with the wound. So what's your experience? I would be happy to hear that. We can speak in Hindi also, no problem. No experience sharing. आप मत सुनो, हमारे यहाँ जो चल रहा है ना.
मोस्ट ऑफ दी जो पेशेंट्स होता है यहाँ पे उत्तराखंड के अंदर, वो बेड रिटन पेशेंट जो बेड सोर के साथ ही आता है. क्योंकि जो भी होम केयर में जितना पेशेंट रहता है उनका उतना अच्छा केयर नहीं रहता है, तो मोस्ट ऑफ द पेशेंट जो है उत्तराखंड के अंदर बेड सोर की वजह से और ज्यादा इन्फेक्टेड होता है अलोंग विद जो कंडीशन है।
Okay. Okay, Manish, thank you, Pankaj, for the response. Manish is saying RTA patient open wound. Yeah. Have you seen tracheostomy patient having maggots? No. Okay, no. Recently, we have got an admission here for a patient who has a CA tongue and he has tracheostomy done. CA esophagus, I think, and the tracheostomy was done, and the patient had maggots. That was very tough to manage, but we had managed pretty well, and we have discharged the patient home. That's an experience from what we face here, and. Mainly whenever the patient come to us, we educate them, and during our home visit we ensure every points are clear. Like reassurance is very important when we are dealing with the patient, so we reassure that whatever we have said, that is clear to them. Like now I am reassuring that my topic was clear for you, right? So any doubts? No, ma'am. Okay. Okay. So hope the session was clear to all. If you have any doubts, you can like you have got WhatsApp group, you can message us and we'll let you know whatever like query you have will be resolved. So thank you so much for joining.
Okay, thank you, ma'am. Thank you for the wonderful informative session. That was a detailed informative session. Hope you all understand. Do you have any doubt or something, Ravina Deshwan? Do you wish to?
No, sir.
Okay, okay, okay. Okay, thank you all for participating. Let's see in the next session. Okay, thank you.